Hello, everyone. My name is Rachel Bockel, and I'm a second-year medical student at Geisinger Commonwealth School of Medicine in this year's VGR chair. I would like to welcome everyone to tonight's virtual grand rounds. We will start off with a welcome message from our AADMD president, Dr. Alan Wong, who is currently hospitalized for COVID-19.
I'm Dr. Alan Wong, president of the AADMD. Welcome to tonight's VGR Community Support Safeguards during the COVID-19 pandemic, which is part of our COVID and IDD series. This webinar series has taken on a new meaning for me personally, because I'm joining you from my hospital bed. I was diagnosed with COVID-19 about 9 days ago and have been in the ICU since, fighting to keep off the ventilator and battling the many aspects of COVID. It's really given a new meaning, a new appreciation of what lies in front of us. This is an unforgiving virus that we'll be discussing tonight, and I'm encouraged by all the partners we have to come together to learn more about and prepare our friends with IDD, as well as our DSPs and family. COVID is something to not take lightly, especially those with IDD. It exhausts you physically, tries to suffocate you in and day out, but I must say the mental battle is quite literally the worst nightmare I've ever experienced. I have a new perspective for our friends, and I have some ideas on how we can help them in the future as I get stronger. What a jarring and bleak reality it must be for someone with IDD to have COVID. I can't even imagine being in a hospital room alone, without any voice, without any support, with everything that's going on. We must help them understand this fight, and more importantly, avoid them from being in it. We must do all we can do to prevent exposure and protect our patient population at all costs. That's why I'm so moved that so many remarkable organizations have come together tonight to join our fight against COVID in the name of the people with IDD and their families. Our panelists are wonderful. They represent the following organizations: ANCOR, NASDDDS, HeartShare, NADSP, the ARC, the Jewish Foundation for Group Homes, and not to mention the wonderful members of AADMD. As a continuation of AADMD's COVID-19 support guidelines, they will discuss the next steps and recommendations to address the critical needs of community provider organizations, their DSPs and people with IDD, and their supporters and communities across the U.S. Thank you for joining us this evening on this very important topic. Thank you for showing up for the fight and being part of our coalition. I'd like to thank you for your persistence and your help in helping our friends to stay healthy. And as we seek our one voice for inclusion, we must remember those who don't have a voice. Thank you for being with us tonight in our endeavor to collaborate. I congratulate the Student Resident Committee of AADMD for promoting and fostering such a vibrant program. I look forward to getting well and being with all of you in person. So, without further ado, I turn this back over to Dr. Rachel Bockel. Thank you all. Thank you for your prayers. I love you all.
And I'd like to pass it over to David Irwin to begin our presentation.
Thank you, Rachel, and thank you, Alan. He may not be able to hear us, but our thoughts and our prayers are absolutely with him as he faces this battle. He needn't battle alone, and I know all of you join all of us in wishing Alan a speedy recovery to full health. Thank you all so very much for joining us this evening. We have a jam-packed hour. I will dispense with the typical introductions, although I would tell you that we have the A-listers in intellectual and developmental disabilities at a policy, practice, and consumer level. I'm not sure that I have been in the presence of a more robust panel. And what we hope to offer this evening is a look forward, next steps. The AADMD about a month ago published support guidelines for individuals with intellectual and developmental disabilities through the COVID-19 pandemic. That white paper is filled with recommendations that can be taken by DSPs, by organizations that support folks with intellectual and developmental disabilities, for folks with IDD and their families alike. And it's a reasonable question for us to ask now, what's next? And so we will take a forward view of steps that we think might be appropriate to take, how we can amass the energy and the intent to fight back against this wretched virus, to keep people healthy, to keep people safe, and to allow people to thrive in their home communities. I want to encourage everyone to please use the chat feature. We hope to make this as interactive as conceivably possible. If you chat a question, we will see it. And to the extent that we can squeeze in questions, we will absolutely do so. There's also a Q&A feature, and you can ask questions there as well. So I'm just going to jump right in, if that's okay with everybody. The paper, David Frey, who is past president of the AADMD, is a clinician himself, as well as an educator, and is unique among us because not only is he a clinician, but he has actually run a state system of developmental disability services. This makes his skill set rather unique. I wonder, David, as you think about next steps, and you think about it through the lens of a clinician, as well as someone who understands how systems work, it seems at times that there could be an endless portfolio of work for us to do to advocate on behalf of people with IDD. What do you think are our next priorities in taking next steps in facing this virus for people with IDD? Unmute yourself, David. Unmute yourself.
Thank you. So with my AADMD hat, I would say that we need to widely spread guidelines, and we need to engage with state directors of disability services, and NASDDD is a tremendous partner in that. I do also think, as a former state director in Hawaii and Arkansas for together 16 years, I can guarantee you that state legislators and state directors are grappling with budget issues. And at the same time, direct support professionals and providers and families are struggling with the need for more resources. And so those two huge drivers are directly opposed to each other. And it's really going to be very important that we prioritize health and safety. And I think that is a strong message. We all need to rethink. COVID's going to make us rethink maybe the way we provide care. So from the healthcare perspective, we'll get into this later, I'm sure, but telehealth is a tremendous benefit. I know in Hawaii, it was an island state. I was state director there for 14 years. And just being able to communicate across the oceans to prevent people from having to fly to Honolulu to see a developmental pediatrician, for instance, telehealth was tremendously helpful. So I think we as health professionals are going to have to be creative and innovative and recognize that we have increasing needs with decreasing resources, and it's going to cause us to prioritize. I just heard today that what's being discussed at the federal level is how to prioritize vaccine and which groups are going to be at high risk. And unfortunately, people with developmental disabilities don't get categorized in a lot of health data. They're there, but they're invisible. And because of that, the amount of need tends to get discounted. And I remember when H1N1 hit back about 2008, 2009, we were on the initial list of high priority, and we were taken, people with intellectual disability were taken off that list. So I think right now is the time for us to be advocates. So I would love to hear from more of our partners. I think providers are having to grapple with, and some of the guidelines that AADMD had put out would be very helpful to providers, but they're having to grapple with what happens when somebody comes home from the hospital post-COVID. They're still, you know, considered contagious. They still might have behaviors that would lend themselves to not be cooperative with wearing a mask and social distancing and touching things. So I think there are a lot of challenges for direct support professionals and providers. And as state agency directors, we need to have some guidelines, but we need to be able to create flexibility. One of the great things about Medicaid is there are many, many flexible options, but it requires your single state Medicaid agency to understand what they need to be asking for. And there's a bureaucratic process that can be sped up. And so I think that right now we're faced with a big problem that we're trying to put our hands around. And just like the coronavirus that's floating behind me in my virtual background, you can't see it, you don't know where it is, but it, you know, it is a threat. So with that, you know, I'm happy to later answer more questions about AADMD and some of the things that we've recommended in our guidelines, but I would love to give opportunity to other panelists. Thank you.
Thank you. Mary, I'm gonna sort of kick this over to you, given David's emphasis, and Barbara, you're on deck. Mary Sowers is the Executive Director of the National Association of State Directors of Developmental Disability Services, NASDDDS. You work with directors from all 50 states. And what if our audience is provider organizations, how can we as providers advocate, to David's point, directly to our developmental disability services system and work collaboratively with those directors? How do you think about and how do you advise provider organizations from connecting to their state systems?
David, that's a great question. And David Frey, I certainly appreciate both your history with our organization and on behalf of individuals with intellectual and developmental disabilities. We are definitely seeing the fact that partnerships are more important now than perhaps they ever have been, and the important role that providers and state agencies can play together along with self-advocates and families really has been highlighted as an essential, not a nice to do, but an essential part of the work against COVID, both in terms of helping individuals remain healthy and safe, but also to address and anticipate the trauma that comes along with such a frightening ordeal for all of the country, including individuals and families that we support. So I think the provider community, I think, and Barbara will certainly speak to this, but I think has been an essential partner throughout every step of the way in the fight against COVID, both in terms of really partnering with the state to leverage whatever resources necessary to obtain PPE when that was an extraordinarily short supply, as well as to engage with the states on testing strategies that make sense, strategizing about services and support models that are going to work for folks in the short run. And so I think that, again, more than ever, the partnerships between the providers and the state, along with individuals and families, has become really a hallmark of how we need to move forward. We are all, while I think most of our members have done a tremendous job with addressing the issues around PPE and testing, it is not lost on anyone that our states are facing perhaps the most impactful budget shortfalls in our lifetime. Certainly and we really need our federal partners to step forward and provide necessary support to the states in this time. But we're also looking at the fall with compounding impacts of potentially the flu and other complicating factors that just brings a lot of unknown. And so it's really necessary that we both sort of think in the short run, but also plan for the future as best we can. And so our members are also really thinking about how to make sure we've got enough PPE, for example, for the short run, but how do we make sure we're well positioned in the longer term? Even as we've seen spikes move across the country, we've seen the availability of testing or the results availability varying. And so close surveillance on those pieces is going to be important too. And I know my colleagues on the panel will speak to the fact that even just the practices around testing are so variable that we really don't have a great handle on the infection rate for individuals with IDD specifically. And so that continues to be a huge focus of all of our members and their partners within the states.
So Barbara, in the AADMD paper, testing and PPE, contact tracing were an area of terrific priority for what is now obvious reasons. And yet Mary's correct. While we all recognize the importance of these resources in trying to control for the spread of the virus at the least, accessing rapid result testing, for example, continues to be a colossal challenge. Accessing affordable PPE when there aren't reimbursement systems to cover those costs is proving a challenge. It sounds like there's certainly opportunities to partner with state agencies, but I know that ANCOR, of which you are the executive director, by way of brief introduction, does a lot of work federally. Where do your members, this is the membership organization for organizations providing services in the country. How are you advising your members to get active, get busy? Is there a specific set of 2 or 3 recommendations that we can give to our listeners as to what they can do tomorrow?
Oh gosh, where do I start?
Right.
Kind of the short answer is I think we are all collectively. And when I say we all, I mean every organization represented on this panel, as well as all of my members doing everything that we can humanly do. It's often said, boy, if the disability community could just get together and agree, the sky's the limit for what we could accomplish, right? So that's always been that recognition that there has been difficulty in agreeing on policy at the federal level. There's just virtually no disagreement right now. People are pulling together. I mean, we are so honored to be working with NADSP, to be working with AADMD, to be working with NASDDDS, to be working with the ARC, to be working with everyone, every person on this panel, mobilizing ANCOR members across the country. So we represent 1,600 provider agencies across the country, in addition to 55 state provider associations. And so we have really mobilized our state provider associations in giving them the tools and the information that they need to push down to all of their members. One of the things that's just been enormously helpful is just that, and all of our national organizations have that. That's the beauty of national organizations. That peer-to-peer, state-to-state learning. So Massachusetts, I was on the phone with Ellen Atialadis, who is the CEO of the Massachusetts Provider Association. And Massachusetts might be unique in the country, Mary, you can tell me, in that the Commonwealth deployed mobile units to all settings where people with intellectual and developmental disabilities were receiving services for everyone to be tested. Pretty extraordinary. I'm not sure there's another state in the country that did that. But in speaking to Ellen today, I found that, that wasn't without some difficulty. And so the Commonwealth is pulling back and not deploying those mobile testing units, but they are paying for testing for everyone on a monthly basis. And in areas that are more severely impacted, they're requiring testing every 2 weeks. And if we could have that type of testing done across the country, what a difference it would make. I was speaking to another one of my members yesterday, who was sharing with me that, they were feeling slightly relieved that COVID hadn't hit their agency that badly. And by that badly, what he meant was only 13 of their staff had been diagnosed with COVID. And only 2 of the individuals with supports. And so that, I'm really looking forward to Joe's response on that. I mean, that's what we're really seeing. You know, it is the staff that is, you know, overwhelmingly, you know, just working so many jobs. And, you know, low wage earners. If there's anything about this pandemic that we've got, I mean, there's so much we are learning from this. But this has got to fast forward what we do as a country to elevate the profession of direct support professionals, because people shouldn't have to be working 2 and 3 jobs. At least one province in Canada, and perhaps the entire country of Canada, one of the things that they did at the outset was, you know, say that direct support professionals could only work for one agency. Can you imagine if we were in a place in this country in order to be able to say something like that? I think, you know, the other thing that we really need to do moving forward is, you know, the CMS has temporarily halted the implementation of the home and community-based settings rule. You know, there are people on both sides of that. But once we are clear of this, I think it is incumbent upon all of us to ensure that the settings rule is implemented across the country, because the essence of it is informed choice. And informed, and there's going to be a lot more informed choice coming out of this pandemic. So what are providers doing? We're doing everything. We've been working with the ARC, we've been working with everyone to make the case and educate everyone that our workers are essential workers, so that our faces are not forgotten faces. And that work is continuing day in and day out, because the 4th legislative package still hasn't been passed.
Indeed. And I should thank, because I'm a beneficiary of it, the hashtag Forgotten Faces campaign on social media was and continues to be a pretty effective and powerful campaign. So Barbara, on behalf of my provider and my community, thank you very much. I want to go to Gilbert. Gilbert Plaza joins us this evening. Gilbert, there he is. Gilbert is a self-advocate with a tremendous portfolio of effective work in New York. Several panelists have mentioned that this is a virus that is being visited on people with intellectual and developmental disabilities and DSPs in ways that we're just not seeing in other segments of the community. Gilbert, I know you've had some experiences right there at HeartShare, and friends and colleagues of yours who have become sick with the virus. How do you advise people who are self-advocates, the consumers of these services, to be fighting back for the protections to lead healthy lives?
Okay, I'm advised for the name to have checkup.
Hang on, Gilbert, I'm struggling a little bit to hear you. Try and speak up just a little bit.
Okay, I'm advised by now to have checkup, and especially who live on the residence. Every residence, every staff who go to the residence, they're not putting the client at danger. But they are could be and then or could be us. Right now, for everything is for us could be outside or inside. We could be a harm way. But now the corona is out of control. It's so much out of control. A lot of agencies here in New York City all lobby. They don't know what to do. How we can have children in New York City or 50 states to have the client who live on the residence, but they go to the staff, how we can have children, the staff or the clients, be sick. It's not a staff, it's not a client, it's the time. The time right now is getting worse. Coronavirus it's not going to go away overnight.
Right.
It's not going to go away a couple months, but it is going to go away. We don't know when. Nobody know how. How we can keep ourselves protected. That's a problem. Even our own family. Aside for my own citizen family, the sick is not the residents. It's everywhere right now. And the coronavirus is too out of control. Even we scared now. A lot of people scared.
Mhm.
Even when we go to the kids go back to school, how it gonna go?
Right.
Eventually,
Thank you. Nicole, I'm going to turn to you next, which means I'll owe Joe a drink at some point, I'm sure. But in addition to being one of the sharpest public policy minds that I know, working on Capitol Hill, you also happen to be a very proud sister. And so you, not unlike David's multiple perspectives on systems, how, to build off of Gilbert's thoughts, how do we mobilize, in your view, what are some effective ways to mobilize self-advocates to join the work of advocacy at both the state and federal level? And then what are 2 or 3, again, sort of looking for some low-hanging fruit for the providers who have joined us this evening who want to go back to work tomorrow and pick up the phone and call a legislator or write a letter, and what should we be really focusing on, and who joins that battle in an effective way based on your experience?
Sure, the boil down I can do. That's one of my specialties. But first of all, the most important point is making sure that Gilbert and people like my brother Chris are the voices at the center of our movement, and also of course the DSPs. But in order to make sure that we are making sure that individuals with disabilities themselves are the voices of the movement, we have to make sure that storytelling obviously remains a central component of that, whether that's storytelling to legislators, to state Medicaid directors, to state legislators, because obviously there's components of this that are at the state level, whether it's deeming direct support professionals essential at the state level, or making sure that happens at the federal level, or making sure that we have additional Medicaid dollars at the state level or the federal level. All that needs to hinges on the voices of people with disabilities. And so to ensure that people, we need to make sure, so at the ARC we have, and I can put it in the chat box, but we have the arc.org /action that has a storytelling tool, and that is tied to our top priorities. And so to boil those down, to Barb's point around the fact that we still do not have a 4th package, even though there was a package that included the main priorities of the disability community that passed the House on May 15th, but still has not had any movement in the Senate. And that bill did include the top priorities that I'm going to talk about. Number 1 being direct funding for Medicaid home and community-based services. It's section 30103 of the HEROES Act. Not that I have it memorized, but it's dedicated funding for Medicaid HCBS. You don't even have to know any of the numbers, just dedicated funding for Medicaid HCBS. That's going to help with the PPE. That's going to help with the DSP issues. And we also need to see more Medicaid funding, but that's the number 1 issue. Also, we want to make sure that there's no barriers to stimulus payments. But for the issues that we're talking about and the issues that tie directly to the AADMD report, that is what I would tell folks to be talking to your legislators about.
Okay, that's great. Thank you very much. And then that's a quick, nice transition to Joe. So Joe, just to give you some, I suppose, scale, I work at an organization. We've got probably north of 220 DSPs, classic DSPs. In my organization, in full disclosure, we've had 12 of those DSPs become infected with COVID. Thankfully, all of them very mildly symptomatic or asymptomatic altogether. But in the state of Maryland, as in many states across the country, we have lost DSPs to this virus. And yet we all agree that DSPs they're the lifeblood of the industry, and with DSPs and self-advocates, telling the stories, to Nicole's point, it seems this is just a no-brainer. What are you hearing from DSP, from direct support professionals? And Joe, by the way, is the exalted executive director of NADSP and is the man representing the interests of DSPs for quite a good long time and at an incredibly effective level. How are you advising DSPs, Joe, to join this fight? How can agencies like mine support my DSPs to make sure that their voices are heard?
Well, thank you, David. And so there's nothing like a once-in-a-century pandemic to lift the veil on the essence of direct support work. We knew in March that direct support professionals were going to be asked to rise to the occasion. And we knew that they would, because they always have. During other crises, natural disasters, hurricanes, wildfires, DSPs show up, DSPs are committed, and DSPs will rise to the occasion. Nothing could have prepared direct support professionals for what happened in March. I live in New York, like Gilbert, and one day DSPs are doing their work, and I always say DSPs, their office is the community. That's where DSPs work, in their office. And then March 14th, DSPs were not allowed in their office, and they had to reinvent and recreate their jobs and help people with disabilities understand social distancing practices and PPE and changing of their daily routines. And they become really creative. They're very resourceful. They're helping people use technology. And we're calling them, like we do in natural disasters, the heroes and the lifeblood and the backbone of this system. If there's a silver lining here, we're going to take this and we're going to use it to affect public policy in the future. Because if they're really heroes and they're regarded as heroes and essential, then we have to pay them more than $12.52 an hour. We have to prepare them with career ladders. We have to give them training in health and safety and prepare for a second wave of this horrible virus. We need to give them good, adequate training. They're traumatized, David. DSPs have been suffering trauma, and it's going to affect them for years to come. So we need to give them emotional support as well as the living wage and career ladders and all of this stuff. Lastly, I think if there's another silver lining to this, because I'm always looking for that silver lining, and our jobs, and Mary and Barbara and Nicole all know, direct support workforce is always, it's reflective of the economy. There's economic factors that play into our workforce. When the economy is bad like it is now, when you have 30 million Americans out of jobs, we have jobs. They will come and be direct support professional. The trick is, how are we going to keep them when the economy improves? We've never been able to do that. I was hired in 1983 during the early 80s recession. I saw people come and go. We've got this churn of people who, many of them are probably very good, effective direct support professionals. And if we could pay them what they're worth, they'd probably stay rather than going into a higher paying job in manufacturing or in banking or something like that. We need to create a profession that is reflective of the work that they do. They're not caregivers. If they've shown anything, that yes, direct support professionals do provide care and focus on health and safety, but my goodness, they're so much more than caregivers. So we have to find ways to keep these new DSPs that are coming into our field. We need to give DSPs that standardized occupational code. They can't be anonymous anymore. We've had employers writing notes to DSPs when they were going to work to show somebody, if they got pulled over, that they're essential. Nurses didn't have to do that. DSPs are anonymous. Nobody knows who they are. So we've got a lot of work to do, but I think there's also some opportunity here.
One of the interesting dynamics that we experienced very early, so Maryland really got broadsided by this into April more than in March. In March, it was still somewhat novel, forgive the pun, but by mid to late April, we were neck deep in it. And what was fascinating to some of us was that we were asking DSPs to, in essence, be essential healthcare workers. So you got me at essential. I'm good there because they have been, are now, and will be essential. But we're asking them to act and understand and have knowledge of healthcare workers where on things as simple as donning a mask, doffing PPE. And we started using this language as if every DSP had been through every bit of training conceivable so that they understood all of this. And yet, I think to an incredibly negative sort of set of outcomes, they didn't. And I wonder, you know, as we think about wave 2 or the continuation of wave 1, I suppose, depending on your perspective, where do we turn for training resources? And this is to anybody on the panel. Is this a discussion that we have with our state directors, our state systems, Mary? Or is this a discussion that we have with our state association, Barbara? Or where do we turn? Because I still don't think that we're suddenly healthcare workers. We are operating in a bit of a healthcare environment, and I get that. But by God, if we don't train folks on what to do and how to do and when to do it, then we're asking folks to enter into a risky transaction without the tools they need to keep themselves safe and to keep the people that they are dedicated to safe and healthy. So what do we do with this? That's anybody. Mary, you're about to speak.
I'll jump
sorry.
in, but certainly am anxious to hear from my colleagues too. I think, David, all of the above is the correct answer on that, and probably many things that you didn't enumerate, because in addition to making sure folks have the basic understanding necessary to keep themselves safe and the people that they're supporting safe, it's going to be important to keep that vigilance up long term. I think one of the things we've seen even in the intervening months since March is that there's a sense of complacency that sometimes comes with the you know, as we become more familiar with the circumstances we're working in. And so I think in addition to understanding the importance of how to use the tools that are available to us and the strategies that will keep us safe, but how do we keep up that sense of urgency so that we have that vigilance moving forward, both as we sit here today with varying rates of infection across the country, but importantly, as we anticipate what comes next. And frankly, you know, what are those practices that we should be thinking about longer term for folks too. So I know we'll talk a bit about what our service delivery systems will look like moving forward, but I think I'm feeling a sense of urgency to make sure folks continue to keep this as a high priority because it's wearying on a lot of folks, right?
You bet. Yeah.
Yeah, I think that the kind of rub is the fact that obviously we have direct support professionals who, to Joe's point, are doing things that are outside of caregiving. They're outside of healthcare, obviously, as well. And we also don't want to put the services of people with disabilities into a medical model. But frankly, probably that would mean better pay. That, you know, and so that's, I know I'm saying nothing new to the folks on the panel, but that's where we really struggle on the Hill and in these conversations. But I do also share kind of in a messed up way the positive tilt on this, because this is exposing it in a way that we've all been screaming into a void about for decades. In my home state of Illinois, I think the average DSP wage is still under $10 an hour, where my brother gets services. And so we need to have a real moment in time about that. And so that we can get the good people that we will get into the field to stay. But it is going to mean that we have to get the occupational code, but also have a firmer understanding of what that means. Just today, a big white paper was released, the infrastructure of care, that combines a lot of these issues. It combines the fact that in Medicaid, for example, home and community-based services are not mandatory, while institutional services are. It combines workforce issues. It combines paid leave issues. So it's kind of setting the stage along with some other things that are out there. So hopefully we will, again, never let, to quote the former mayor of Chicago, never let a good crisis go to waste, Rahm Emanuel. But I think that medical model piece is something that we really struggle with, especially in the workforce area.
Sure. The other thing, the other piece to this is so it was well and good to finally find sources of training and education for our DSPs, right? Here's how to don, here's how to doff, words that I never used before this crisis. And then we applied what I would consider to be, sort of tried and true technology to the notion of supporting folks receiving services to wear masks. And we talked about desensitization and what that means. And I think what we did, and I'm being intentionally a little sort of self-revealing here, is we forgot that context in fact matters, right? That folks receiving supports are every bit as freaking out about this as everybody else is because they're experiencing it intimately. Gilbert, I wonder if HeartShare and your work there, how you and others receiving HeartShare supports sort of contemplated or thought about yourselves wearing masks. Like, that's not something you would normally do. And I wonder how you experienced that struggle of learning how to wear PPE and learning what PPE is and why it's important. Maybe you could unmute yourself and comment on that. Unmute yourself first. There you are.
That is something we have to get used to it now. It's for us, it's for you guys, for everybody. It's a part of life now for all of us. Especially when you wear this all the time, some people can handle it, but some people can't. That's a problem everybody having now. To have it on for many hours a day, some people say, I can't live with this. I need air. But to get air for this, it takes time. It's going to take more time. But it's about the life right now. Mm-hmm. For us, especially for the people like me, and for the people with disability, that's going to be a challenge for us. Some people can handle it, but some people can't.
That's me. Yeah. So, to the provider agencies that are out there listening, it sounds like Gilbert's message is patience and stay with it. And on a hot day, wherever you happen to be doing your work and you're wearing that mask and it's uncomfortable and it's not necessarily the most pleasant thing that we do. And yet we have to figure out how we support folks in getting comfortable with that. And patience matters and repetition matters. And the other thing, I guess, and I wonder, Nicole, if you've got any thoughts on this, or Barbara even, for that matter, from a provider's perspective, one of the interesting things with which I think we're struggling a little bit is the tension between self-determination and what is considered to be healthy, safe choices, right? So I want to go back to work, says Johnny. And the provider agency is completely freaked out because if Johnny leaves the protective seal of his home, then surely he puts himself at risk. And that's a scary proposition for providers. And yet we are dedicated, we surely must be dedicated to the notion, the fundamental notion of choice and informed choice and what does it mean and all of that. It's sort of an interesting dilemma that is emerging from this exercise. And I wonder if there are bits of advice that you can give to our listeners around not only how to interact with tension. But what do we do with it when we go to speak to legislators and speak to other public policy folks in order to get their help and support as we continue through this?
I'll leave that one to Barbara mostly, but I just wanted to highlight that that tension is not just between individuals and providers. It's also between individuals and their families.
Yeah.
About safety. And so just wanted to throw that out there.
It's really important. Yeah,
Yeah.
absolutely.
Absolutely. And, you know, and individuals and their neighbors. And, you know, I mean, all of us, right? We're all, you know, dealing with and trying to navigate this. And the more that it can be we-based, is, you know, you know, is just such an important approach that we are all in this. And, you know, so this pandemic has, you know, you ask a big question. This pandemic has clearly really exposed, I've said this a few times before, so for those of you who've heard it, it's really exposed the weaknesses of the state-federal partnership. You know, it really kind of matters where you are in the country with respect to how much information has been forthcoming. You know, it just matters more than it should. So, you know, Nicole, in your home state of Illinois, didn't we read that, you know, the National Guard, you know, had to go in and provide staffing for a state-operated facility
Too.
in Illinois.
Oh.
In my home state, in Maine, the National Guard was deployed to go around to agencies and provide proper fit training. Because you brought up the question about training earlier, David. I just, you know, think that we really need to look at this in a much larger way. You know, I love, you know, Joe's looking for the silver lining, because that silver lining is where we've really got to go on this. But, you know, this, I mean, you know, it's too much of a patchwork. You know, that's why I said at the top of the hour, that's why national associations, all of our national associations are so important. And I, you know, and I wish that ASAN and SABE were also here, because the information that we are giving folks on a national level, I think has just been really, really helpful to fill the gap. But I want to be much more specific. I want to thank NASDDDS and Mary Sowers and her incredible team for putting together the reopening guidelines. We've pushed that out to our members, and I'm getting really very, very positive comments from it. And so you ask specifically, what should providers and advocates and family members be doing? You know, going to their state and really strongly advocating for, you know, cohesive statewide reopening guidelines, because this tightrope, you know, this fence that providers are walking between the need to keep people safe while respecting people's need to be able to live like anyone else, it's just incredibly tough. So we'll all benefit from some, you know, from instructions and guidance at the state level that will really help. And so, Mary, thank you. I think maybe we ought to push that out in the chat box, because I think that was just a terrific document.
Well, thank you very much, Barbara. We have and I appreciate.
Hold your mic up to your.
Thank you very much, Barbara. We've got, you know, it really is just a reflection on so much of the good work that our members in partnership with many of your members have done. In fact, it was really a curating of a lot of good resources. I think one of the things, David, to your question, is that there's not sort of a one response, as Barbara and Nicole said, but indeed really looking at the systems level, the provider level, and the individual and family level, and really taking those person-centered approaches, both to helping make sure folks have, you know, are exercising as much autonomy and choice as they can within the circumstances with which they're faced, but also just to provide that framework and to be able to have those conversations on a really candid manner. I think this whole pandemic really has laid bare a lot of the vulnerabilities in our system, largely the DSPs, who continue as Joe mentioned, to show up, to carry the weight. And the complicating factors that they face on a day-to-day basis can't be overstated. I think we are only beginning to see that as we begin to enter the school year, and parents are expected to help support their children during the school day. Well, many of our workforce is really going to be challenged by that in a way that, of course, all parents are, but there's just many complicating factors that we're going to be facing. So it's really got to be, as we're thinking about reopening, and that's always, I always keep saying that it's almost the wrong term to use, because it's not going
We never
to be
closed.
normal. That's
Yeah.
right.
Yeah.
It's going to be, how do we move forward, and really try to take a methodical and thoughtful approach, and know that we are engaging with our members on continuing to refine that work, because we know that we'll learn more as states enter this unknown territory with their partners. So thank you, Barbara. We'll definitely share that resource, and appreciate the shout.
Great suggestion, thanks. David Frey, I'm going to ask you to pop back in, because I want to sort of turn us a little bit towards, David, I assume you're still out there somewhere. And if not, that's okay too. But where
I'm here.
There he is. What I thought we might spend, we got about 10 minutes to run here. I thought we might spend a little bit of time. You mentioned at the top, a need to think about and plan for, what do we do as organizations? What do we do with clinicians in the community, in our local communities? How do we engage them in ways that make sense, both at a prevention level and, once the virus is in a community, it takes a different shape and form. And so too do are the things that we need to be doing to keep people safe and healthy. What can you suggest in sort of layman's terms for folks listening, many of whom are providers, can be done? Are there some steps that extend out of the white paper that we published a month ago? What's our current best thinking on clinical next steps as we try and wrestle with this virus?
Well, I would say, first of all, before we get into clinical next steps, I think we need to always be person-centered. Somebody had mentioned self-advocates becoming empowered. I think people like Julie Petty are outstanding leaders, national leaders, Ari Newman. What we really would like to do, I think, is to have a one voice. Now, we have used that in AADMD, and we really would like to create collaboration. We'd like for ANCOR and NASDDD, for all of us, maybe to take these original guidelines that we put out in a white paper and expand that. I do think that people need practical answers, but there are policy decisions that need to be made as well, both on a national and state level. Getting your governor in your state involved in prioritizing health and safety for this population is essential. Being able to provide good leadership for families, DSPs, providers with the guidelines. So I think that having other organizations not just sign on to the guidelines, but expand those guidelines, and for us to use the power of families and the power of peer mentors, I think those are essential to try to put action to words. So I think we worked hard to try to bring this up as an issue, and I'm thrilled that we had the participation that we had tonight, but I think it's just like sticking your toe in the water. We all need to jump in the pool and we need to swim the same direction. So I do think that there is a lot of misinformation. We're having to learn with uncertainty. Last week, the FDA said convalescent plasma is okay to use. And today the NIH said there's no evidence to support that.
That's right. Yeah.
So I think as clinicians, being able to get evidence-based medicine recommendations at the highest level with, systematic reviews and meta-analysis, that's not going to happen in time. We can't get there quick enough. So we need to have a way to share information. One of the things that we're doing with AADMD is provide webinars. And so I would encourage people to ask their health providers, are you a member of AADMD? And if so, they get e-blast. And so it's anybody that's a partner organization can share an e-blast through our network. So we have a quick way to get good information out to healthcare clinicians. But I think that as physicians, doctors, therapists, nurses, I think we all need to know, well, what's really right. And so, you know, we're dealing with a virus that changes transmissibility, that mutates. We're trying to come up with treatments while we're waiting on a vaccine. And at the same time, we want to recognize people's right for self-determination. We want to recognize inclusion. We're going to have to, this probably is going to last for a lot longer than just we're going to deal with this with a vaccine. I think there's going to have some long-term ramifications toward policy. I think telling state Medicaid agencies that the home and community-based waiver is kind of an afterthought, that people can get on a wait list, really has pointed out that there's a lot of folks that need better support. And we really do need to, I think, probably to do what we did for children with EPSDT. We need to say, okay, we need to have some mandatory things that are really straightened out here. But it is difficult to balance both health and safety and budgets and self-determination. So all of those are big challenges, and that's why we need everybody on board contributing. I don't know if that summarizes, but that's from my heart. Thank you.
Yep, no, it's good, David. We have about 4 minutes left. I want to let everybody who's joined us this evening know that on October 22nd, you will get more information on this, but on October 22nd, we will present the second in a series now of webinars specifically addressing the community of folks with IDD and COVID-19. That second, that 2.0, if you like, will be with an eye on nursing and where nursing fits into the COVID-19 response, both in terms of prevention, in terms of training. Some of the questions that I asked earlier today, we've got a good number of extraordinary nurses listening in, and they have hastened to remind us that nurses are rich resources of not only expertise clinically, but also who have dedicated themselves to the purpose of preserving health among folks, supported by organizations just like mine. So let us not forget our nurses, and I hope that everyone will join us on the evening of October 22nd for our second in the series of webinars, this one specifically on nursing. I'm going to ask each of you to spend 30 seconds, and I'm going to cut you off, so be precise. What parting thoughts, either some inspiration to people listening who want to go to work tomorrow and do something, actually feel like they're moving the dial, or sage counsel, advice, something that they can do that will change their little corner of the universe. What 30-second snippets can each of you offer? Mary, I'm going to start with you and hold your mic up to your mouth.
Thanks much, David, both for the tee-up and the reminder. And boy, 30 seconds seems awfully short. I think really engage in meaningful conversation in your state and with your partners. None of us can do this alone, and it becomes extraordinarily important that we really have relationships at our core, and that we're keeping individuals and families in the focus, but really build those relationships. If you have them, make sure you're maximizing them. And of course, we are much like Nicole and Barbara, any pressure that can be applied to make the wheels of federal government move a bit more expediently would be terrific. So
great, thank you. Joe?
Quality is defined at the point of interaction. We've known that for decades. I think that nothing is more important than understanding that right now. I would say that DSP week is coming up September 13th through the 19th. I would hug a direct support professional. I would say, thank you very much, direct support professionals, and let's work together on trying to get a career ladder and a standardized occupational code for you.
Excellent, thank you, Joe. Nicole?
I would just amend that and maybe say virtual hug, Joe, but other than that, just, but so I would say, that, we really can't change things unless folks understand where the changes need to happen. And when we talk about all this, all of it starts and ends with Medicaid funding. And in order to start and end with Medicaid funding, folks need to understand what that is. And it is a state and federal patchwork partnership that is broken, as we have discussed. Folks need to understand that. Individuals who receive services that need to understand that. We saw during the fight in 2017 the big misunderstandings that there are. We've done a lot of work to change that. We need that education to grow. So I would say talk to everyone you know, educate them about Medicaid, educate them about home and community-based services, HCBS. That's what I do with anyone, because that doesn't have political lines. It just has, it needs to have understanding so everyone can support it.
Thanks, Nicole. Gilbert, 30 seconds of deep wisdom, my friend.
For me, be careful. Did you go to work? Just, did you not feel good? Just go home.
That's outstanding. Yes. Very well said. Barbara?
There's not a whole lot more I can add. I've put some stuff in the chat box. I would say respond to every action alert that comes across your desk and send it to everyone you know. Tell your story. Insist that our faces, your faces, not be forgotten. And then lastly, take care of yourself. When Joe talks about people being traumatized, we all, this is a long haul here, and we all need to engage in what I like to call radical self-care. We got to take that oxygen first to ensure that we're there for everyone. So thank you for the opportunity to be part of this panel.
Excellent advice. And David, we end where we started, my friend. 30 seconds of sage wisdom.
Well, I just want to thank everybody for being here. I think we're stronger together. I think we need to advocate together. We need to encourage self-advocates and families to be heard, and we need to help them be heard. And we need to be influencers in our circle of influence, whether it's local, state, whatever. But then lastly, and this is a small thing, but I work in a clinical setting in a medical center, and we all walk around in mask and face mask and all this hats and glove, everything. We're covered up. And people that we work with, that we've been working with for years, we don't recognize each other. And I can't imagine the impact on a person with intellectual disability for all the people in their life to all of a sudden disappear and be replaced with all these people that look like they're a space astronaut. And I think one thing, and this is very minor, is encourage people to get a big picture of themselves that they can hang around their neck so people know who you are. And I think that it's a minor thing, but I think it would be reassuring. And
Minor thing with major implications.
With that, I'll close.
Yep. Well, listen, you guys are complete and utter rock stars. What an honor and a joy for me to join you for this conversation. To everyone who joined us tonight, thank you so very much. Go back to work tomorrow and pick something to get done. Stay safe, stay healthy, look after one another, look after yourselves. Have a wonderful evening, and thanks very much indeed.
Aloha.